Hello everyone, this is Xiaobing Gong from Beijing Peking Union Medical College Hospital. Today we are very honored to invite Dr. Harry Reich. Dr. Harry Reich, how are you?
Good today.
Yeah,
Good.
we are here because you see that the Dr. Reich's name is here, and we are very honored to invite Dr. Reich here, and because he did the first laparoscopic hysterectomy in the world. That's in year 1988, right?
1988.
Could you give a brief history story about that hysterectomy?
Well, first I'd like to say Thailand has been wonderful. It's been a wonderful meeting, and just very friendly people. I think everybody who came to the Congress learned a lot. So we had a good time here. But for me, back in the 70s, I got interested in laparoscopy, and I also was very interested in vaginal surgery, and I did almost all my hysterectomies vaginally. I didn't like open operations with a big incision. So somewhere around 1980, I decided to look in with a laparoscope on operations and sometimes free the ovary or take down adhesions or excise endometriosis. And then I do a vaginal hysterectomy.
At that time, you can just do this laparoscopy to remove some cysts, right?
Well, I did my first laparoscopic oophorectomy in 1976 with bipolar.
Yeah, that's
so
quite a long time.
That was the first with bipolar. So in the 80s, I would do mainly vaginal hysterectomy. But if there's any problem vaginally, I use a laparoscope. And in
confirmed any injury or to
sometimes.
So at that time you just rule out some complication of your hysterectomy.
Yes.
Right?
Yes. It's great if you think there's a problem with bleeding after a vag hyst to look in with a laparoscope. But in 1988, January, I had some students from Massachusetts who came to see surgery. I only had one case, and it was a large fibroid uterus, and I decided to do the whole thing laparoscopically. So before that, I would just do the upper part laparoscopically, but in this case, we did the main artery to the uterus, the uterine arteries, and then we opened the vagina where it met the cervix laparoscopically. And before that year was out, we did everything laparoscopically, including suturing the vaginal cuff, which to me is the most important part of the operation, now known as total laparoscopic hysterectomy.
So at this time you use a bipolar to ligate the artery?
I started with bipolar and then I went to suture.
Okay.
And I think for the uterine artery it's always safer with suture, because with suture, if you ever do come close to the ureter or get the ureter, you could always take the suture off. With bipolar, I mean, what can you do? I mean, it means the implantation of the ureter into the bladder.
Okay, maybe at that time you worry about the electro injury?
Not much, because we had bipolar.
Okay.
And bipolar is, the electricity just goes between two electrodes back and forth. So as long as you could see the tip of your instrument with bipolar, you don't worry about the current going through another organ back to the machine.
That's the world's first total laparoscopy.
First, but I like to caution everyone that total laparoscopic hysterectomy is not done in many places properly. It's very important to do suturing of the vaginal cuff for support. And I see too many places where they do a laparoscopic hysterectomy and just close the vagina with the vaginal skin, which is epithelium, instead of using the ligaments of the uterosacral and cardinal. If If they don't do that, I don't think it should be called a total laparoscopic hysterectomy.
Okay.
Because it will lead to prolapse in the future.
That's a good idea, I think. I think if you search it laparoscopically. And could you please introduce some new things you are doing now? Anything new?
Well, not much real new, but we've been working on the rectum, excising endometriosis lesions on the rectum for the last 20 years. 20 years from 1989, but for most gynecologists, it's not only new, but it's something that the general surgeons are taking away from the gynecologist. So most gynecologists, if they have a rectal problem, call a general surgeon. But the problem is that general surgeons don't know anything about endometriosis. So the patient really needs a team approach with a gynecologist and a general surgeon today.
So for the DIE patient, will you do the resection? Sometimes will resection of the rectum. Sometimes with the sigmoid.
For me, I resect.
You will?
But nobody else is anymore. I mean, most gynecologists, they do all the work to get ready for the resection, and then they call a general surgeon in, who's in there for 5 or 10 minutes for the resection. That's not fair.
Okay, thank you for your time, and we are very honored to meet you here.
Thank you.